People holding hearts before charts, before meds had names, we had compassion. This one's for every nurse, past, present, and future. Let's go.
We are the calm in the storm, the beacon of hope. Every beat, every breath, we honor the oath. From night shifts to day breaks, loving our tone. Pepler taught us, connection heals more than alone. From Florence to futures, we redefine care, not just meds and machines. We're presence of prayer, with hands that comfort, eyes that see truth. Healing ain't a chart, notice what we do. We are nurses.
Welcome back, everybody. This is another episode of Peplow's Ghost. We've been gone for a while. Gosh, it's like we took a long spring break, but we're back and we're excited. We've got some great guests here to meet. Dr. Joy Lauerer and Hannah Robidoux. I messed that up. I did. God, I get pressured with that. Sorry. Can you pronounce your name? Make sure I'm getting right.
Robidoux.
Thank you.
Yeah.
And then I'm, of course, joined with my buddy, Dr. Melissa Chapman-Hayes, who's always here as well. So I appreciate it. So just to kind of give everybody an update, Joy and Hannah, they're both from the Medical University of South Carolina. Joy is the PMHNP coordinator, and Hannah is one of the instructors. We were just talking about enrollment and how your program is growing and growing and growing. I think that's something that we all see within our psych mental health nurse practitioner programs. But we're here to talk a little bit about psychotherapy. So I'll start us off and just kind of get your guys' perspectives on when did you first get interested in psychotherapy? Both from maybe, a personal point of view or a professional, or from practicing or just kind of getting some exposure. What kind of, lit that spark, lit that fire within you to kind of, want to kind of keep this in the role as well?
I can start if you want me to, since I'm probably the most senior on the call. I started practicing like 35 years ago, and I had done my own psychotherapy from some issues from my family of origin and found it very valuable. And never really wanted to rely on medications for anxiety. And so really got a good therapist and really learned what can change, how my own well-being changed. And then bringing that into my practice as a psych NP, I was trained as a CNS originally. And so I got a lot of psychotherapy training in my program at Wayne State in Detroit. And I've always carried that with me as really valuable and took it to, I'm currently not the lead of the Psych NP, Hannah is. I'm now adjunct faculty and I am working more half-time in private practice. But Hannah and I developed a course in psychodynamic psychotherapy for Psych NPs. And we found that the students who were coming to our programs were wanting very much to learn psychotherapy. So we were excited and we added that as a activity for them.
Mm-hmm. Yeah. I would say a lot of my motivation and passion I went to the University of South Carolina and I got a Bachelor of Arts in Psychology. And after that, I was kind of like, I know I want my career. I'm passionate about this. I want it to be involved in psychology in some way. But I also had this interest in nursing. And at that time, I didn't really know that there was this career that could really combine both of those things. So I ended up, after I graduated, I went to MUSC, and that's where I met Joy. And she was teaching in the psych courses at that time in the Bachelor of Science of Nursing program. And so when I met her, she was working as a PMHNP, and from there I could see how you can incorporate both the medical side of care and having that therapeutic psychotherapy side. And so from her teaching and mentoring and through the programs that I went through and the courses in that program, I mean, that's when it all kind of clicked for me that I could hold on to the psychotherapy piece and also have the nursing component. And so that's really important.
Yeah, that's great. Thank you. And apologies, Hannah, for kind of demoting you. and sorry, my internet sleuthing didn't work so well, but thank you for correcting me, Joy. I appreciate that. But yeah, I mean, I hear a lot of similarities from kind of my path as well. It's, trying to find, where this kind of all fits sometimes is a challenge. And especially, as you mentioned, Joy, too, with the CNS role kind of being retired and things, it's one of those things that it's not been a very clear path of how to do this, but appreciate you guys sharing your journeys here. Thanks.
Right. So I agree. I love hearing about how people come in, especially when it's kind of not the most linear path into what you do and are passionate about. So I'd love to hear from each of you if you remember either the first time or a really memorable time that you performed psychotherapy, and what did that teach you? And either one of you can jump in. Yeah, it looks like Hannah's maybe going to jump in.
I was just thinking, and I was actually thinking about this the other day when I was talking with a student. When I was actually a student, and Joy was actually my preceptor at that time, and we both work now with child and adolescents mainly. But we were seeing a kid, Joy, and I don't know if you remember, but she had pretty severe OCD specifically around contamination in like car tires. And you remember she would get very worried that if she touched the car tire accidentally, if mom did, it caused some like severe anxiety for her. And so as a student at that time, I was like, okay, really focus. What's the diagnosis? What's the evidence-based medication? What are we going to do here? And then Joy kind of helped me see like that's important. We started a low dose SSRI for her after talking with her family. But then it all shifted kind of to focusing on the psychotherapy piece. And I realized I was getting too lost in the diagnosis, medication management, and I really needed to step back and say, what's the bigger picture here? And so the medication then became really secondary. And so that's something that I really kept with me throughout the rest of my clinical experiences. And then as I graduated and became a provider myself, it's not always as much focusing on the medication as you initially think it might be, but how are we using that secondary to, the therapeutic tools that we're using with the patient and in some cases their family.
I remember that client, Hannah, and we both went outside with her and we did some exposure therapy around the fear of the tires. And that was really kind of moving that we both remember that.
Yeah.
Joy, would you say, do you have a different experience? And just as a comment, I love that you two had that experience of remembering and doing the work together.
I mean, I think early on I was trained in CBT, in ACT, and in some PTSD, trauma-focused CBT. So I used that in the very beginning. And then I got really more interested in psychodynamic approach and melding the psychodynamic approach with the CBT. So Hannah and I started using the Deborah Cabanas textbook, Psychodynamic Psychotherapy. I think she's at NYU, and she was doing it with residents. So we brought it into our program. And I think I love it because I love that you can take some of the CBT activities, marry them with other psychotherapies, and come up with like the students have a toolbox of skills that they can bring all things together.
Thank you.
Yeah, that's great. I mean, I'm my next question is a little bit, what kinds of forms of therapy are you drawn to? And I think that's, Joy, what you just kind of talked about. So yeah, so I'm really intrigued by you mentioned, the psychodynamic, and I guess I missed, is it a course or is it a fellowship, or could you talk more about that? And you and Hannah kind of run that, I believe.
Yeah. So currently, I retired last year and I'm adjunct, but I'm working still, and I work with Hannah still. And we developed a semester module course for the psychodynamic psychotherapy. We did it as one semester, then we developed it with a second semester where they followed up with some clinical practice. And we took some lessons from the Cabanas book and just kind of put it into this course, had students really be reflective. We did it all on Zoom and met every other week for 15 weeks. And just really, and we chose students, they had to apply. We chose students who were really interested in developing some psychodynamic skills, because not all of our students are real therapy minded. And so it was important to us that we had students who were. We also brought in Dr. Melnick's COPE and CBT. I mean, so we have a lot of strong psychotherapy in the curriculum. We also are fortunate to have psychologists on our nursing staff, college staff, and they do a lot of trauma-focused CBT. So fortunate that way to bring in behavioral activation and really kind of giving, like I said, I hope when the students graduate, they have a toolbox of skills. Not just one therapy.
Yeah. When we were thinking of developing this and kind of what led to us wanting to create this like program or training, it's just this increasing complexity that we're seeing of patients presenting in clinic. And we really wanted students to be able to think more in depth about the underlying causes of the symptoms that the patients are presenting with, and just really shift into that deeper level of like understanding and like questioning with the patient.
That's great. Yeah. I guess one of the questions too, just maybe follow up, is you mentioned it is kind of a selection process. So a student has to kind of apply and show some interest and maybe some, kind of innate introspective kind of leanings. and I don't need exact numbers, but what percentage about of students going through your program either want to do this, or do you have to turn people away, or is it just, anyone who shows interest kind of thing?
Maybe 10%. I mean, I would say it's not a huge, maybe 25%. I mean, if we had a cohort of 20 students, let's say 6, 8 would
Okay.
apply. So
Mhm.
yeah.
Good.
Yeah, this is something additional that they're kind of like adding on to their training. And, part of the second semester, what we did is we had this like case supervision kind of with them where they were working with the patient in the clinical setting with this specific type of psychotherapy techniques. And they were then bringing that to our different case discussions. And, we were giving them supervision on the patients that they were working with in clinical.
Oh, I see. Good. And do you, sorry, I'm just kind of maybe thinking out loud here. It's one of the things I've been thinking a lot about is, how can we get students in psych mental health nurse practitioner programs, to kind of be interested before they get into programs. So thinking like at an undergraduate level or something like that. And I know sometimes undergraduate BSN programs are at times kind of, limiting their psych mental health rotations and things like that too. So did you notice, besides kind of just having an innate interest in doing therapy, do you notice anything else that's unique about the background of that 10 to 25% who want to go into this class that you offer, which sounds like an amazing experience?
I think they want to really develop relationship skills. And I think that, as I'm practicing more now, I have probably about 25% of my patients not getting well on medicine that I think desperately need psychotherapy. And unfortunately, in my community, there's a huge shortage of therapists. And so I don't know if you saw recently, the Wall Street Journal last week had an article about where have all the male therapists gone. And there really is a shortage of therapists. And that's why I think it's really critical if during a session, and even if it's a 30-minute med follow-up, that, I always encourage students to do 15 or 20 minutes of some, really exploring feelings, setting goals, thinking about, what kind of changes patients make. Because a lot of times you're not doing a lot of med changes in those follow-ups, but you have time. And students were often saying, I don't know what to do. So that's kind of what drove Hannah and I to develop the model.
Mm-hmm. I think a lot of students' personal experiences maybe made them more interested in this opportunity. But I think you mentioned something really interesting. When they come into the program, some students may not realize how important this is and that it's literally happening even in those medication visits. It's about building the relationship. And so you're always having, these types of conversations with patients, your relationship building, you're helping them make sense of what they're experiencing, guiding them through this whole process, the treatment plan. So it's not just about treating symptoms, and it's about treating the whole person. And so kind of helping them understand that as they're getting started in the program, and that further as they continue in the program, now they're learning how to implement these different skills, and we're trying to teach them that in the discussion boards. And we're not just talking about the medication because that's not going to fix everything ever. So they need to learn the other skills too.
Yeah, I keep hearing both you guys talking about that relational side of things, and that's so impactful. I mean, I remember, and I need to turn it back to Melissa. I'm sorry to be consuming, Melissa, but it reminds me too of kind of where we started with this kind of this project of hearing people get out of school and then they're seeing like 25, 30 patients a day, and it's just we've all heard the term of pill mill, where they're just kind of cranking over, and how it leads to burnout, how people just are just not satisfied. That's not why they went to school. They don't see really much impact and change. So it's medications have a place, and they are life-saving in their own way. But that relational piece, I really love how you guys kind of were both kind of hitting on that. So Melissa, I'll shut up. Thank you.
Yeah, all good. Actually, another thing that you both said, Hannah and Joy, is talking about integrating those relational skills into the, medication consult and all of these smaller moments, which we've heard iterations of over many podcast episodes. So that leads to my question of how do you see nursing being a leader in performing psychotherapy? Since there are other professions that do psychotherapy, how does nursing serve as a leader?
I think we have to make sure we have the curriculum, that supports teaching psychotherapy, understanding that our role is unique in that patients are often seeing us for medication management. But I think really important to teach the model of holistic care where you're trying in an intake to decide, okay, what part of this can I treat with medicine and what part of this needs to be addressed in psychotherapy? And I often work very closely with the psychotherapists in my practice so that in my sessions, I'm reinforcing what they're working on with the patients.
Mm-hmm. Yeah, absolutely. I'm in a similar setting where I have psychotherapists that work with me too. We're in an integrated and pediatric primary care, which is amazing, but still using brief CBT strategies, helping a patient reframe a thought that they had when we're talking about different things in session, and it just comes up naturally. And so like, okay, now let's talk a little bit about that automatic thought that you had. You can really weave it in nicely. And I think just validating, building insight with patients and their families, it really helps them connect the pieces because, I mean, similar to students maybe coming in not realizing how important this is. Oftentimes, I mean, you guys know we see the patient or the family come in and they're just like, we need a medication for this, we need to fix this. And it's like, medication is not going to necessarily fix why you're having these behavior problems at school or at home. It can maybe help with some of those things, but there's a lot of other things we need to talk about too in order to get everybody functioning a little bit better.
Thanks both. I just really love to hear like little examples of how you can weave in CBT here and there and just even noticing it because you have the training, like you said, Joy, in the curriculum to know how to integrate that into those experiences. I'll pass it back to you, Dan.
Important what you
Yeah,
said, Melissa, about burnout, and I think, Dan, you mentioned it. I know that the thing I miss the most when I'm with patients all day is having anyone to talk to about the work I'm doing. And so I think we have to figure out a way to provide some clinical supervision, debriefing for people who are doing the 20. I'm not seeing 25 patients a day, but I might see 10 yesterday, right? That's a lot. And so it's often, I'm by myself with those patients. So, and I don't see a lot of practices where there's built-in clinical debriefing, sharing, and I'm trying to develop that in my own practice because I can see that I could start to get burned out if I don't have somewhere to talk about the work I'm doing.
Mm-hmm.
Yeah, I agree. And I might say just what you started with. I think it goes back to a bit of curriculum, and so just kind of making that a priority. And so, I know with students that I work with, we've been doing a CBT group in our local county jail, and we make it a priority after the group. We're going to debrief. We're going to make that something that they find valuable. And will they carry that on in their clinical practice? I mean, I think we all can unfortunately know why we don't do more debriefing because we can't bill for it, and there is a financial stress of it. But it's one of those things that does add a lot of value, prevents burnouts, and I think it keeps us sharp too, right? We get to hear from other people. We get to hear maybe some of our blind spots that maybe we're having. And so it's such a valuable tool that I think we just kind of get waylaid with all the work that needs to be done for sure. So yeah, I think, that kind of maybe leads to my next question of, are you concerned at all about psych mental health nurses using psychotherapy? Is there, thinking about the students that you've trained and the experiences you've had both in clinics, is there, because we hear the barbs, we hear, people kind of, threatening against our scopes and standards of practice. What do you have any concerns about psych mental health nurses using psychotherapy?
You want to address that, Han?
Yeah. So I guess I'd say it depend on how maybe they're taught. And again, like knowing the importance of the reflection, the supervision pieces, knowing the elements of documentation that are necessary to include, and knowing when you're getting in under your head and maybe you need to reach out for help or support. And that's where that supervision piece is so important that maybe you may not realize it in the moment, but when you're like kind of debriefing with someone, you're able to recognize then is that maybe I need to take a step back, maybe I need to refer. But I think it's definitely something that is within our scope, and it's a service that we're able to provide for patients and to help them get better. I mean, it's so important to what we do.
I get worried, Dan, about the psych NPs that aren't getting any training. There's a lot of for-profit programs that don't have real rigorous curriculum, and then they get out. And I think when you only have a prescription as your tool, you're really limiting yourself, and you are going to not always be able to help patients feel better. So I guess I hope we move forward in sensing that this is a really important part of curriculum.
Mm-hmm.
Yeah. And just want to say thanks for both being on here. I think because, this is one way to kind of shout into the void a little bit and kind of, keep the flame burning. But I know in previous episodes too, we've talked a lot about that, and again, this was changing for me when I've been doing the podcast as well, is this idea that I've thought of psychotherapy as an intervention always, but it really is a part of our assessment. It's how we view people. It's how we formulate the cases. It's, it even goes into diagnosing. I mean, how you utilize those psychotherapy theories really does kind of guide your entire practice. And you're right, Joy, when all you got is a prescription pad, then you really kind of are very reductionistic in what you're doing, and you kind of reduce it all down to a diagnosis. And again, I think, psych mental health nurses are probably maybe unique in this way in that we don't want to do that. And so maybe I'm wrong. Melissa may challenge me and say, no, psychologists like that too. So that's good.
Well, I feel like we've spoken to a little bit of the barriers, but maybe we can go a little bit deeper into, maybe you want to mention like one or two of the biggest barriers to PMHNPs using psychotherapy in their practice, either in this integrated manner or, it's more of a longer therapeutic component.
I think the biggest thing for Hannah and I was there is so much crammed into curriculum already to try to get students prepared for lifespan practice. And we were just always stretched to figure out where could we put the psychotherapy curriculum alongside of everything else to show that it is as important. And I think that, programs increasingly, when Hannah and I have presented at APNA, people will say, I think this is amazing you were able to do this. We could never figure out how to get this into an already packed curriculum. So I think we have to be really innovative about making sure that we are integrating it.
Mm-hmm. And I think also for programs, when they're integrating these things and they're, teaching different therapy modalities, so we're covering CBT, psychodynamic approaches, family systems, whatever, are students able to learn the theory, but then also know when to apply each approach? So that's really important. And one thing that we focused on is helping probably a high majority of our students get a psychotherapy rotation as a student and as part of their clinical experiences, so that they're actually able to see how that's done, either with a PMHNP or with a psychotherapist. Having that experience as a student, as well as learning about it in the courses and integrating it in the discussion boards, is very important for us to be able to see that they can actually apply that knowledge and the techniques that we're trying to teach them, and what they can learn with their patients.
Yeah, those practical experiences are just invaluable. Yeah. Sorry, Joy.
We also started to do, which I think is really innovative, when we have students do OSCEs, where we see them actually interview a scripted patient, right? We're in a one-way, we look through a mirror and we can watch the whole interview on recording and everything. We started to say, okay, as part of this visit today, this 30-minute visit, you will be doing some follow-up CBT. So students automatically started to understand that this was going to be part of the medication visit, the follow-up. And so it was great to be able to see, and some students were better than others, folding in the CBT work. But once we really told them it was going to be part of our, supervision of their OSCE, they took it much more serious.
Mm-hmm.
That's great. Yeah. I love, putting students on a little bit of a, setting them back on their heels a little bit to see how they respond. I think it's a great learning experience, although the students in the time, and I know if I would put in those situations, I would not like it, but we need to be kind of pushed every once in a while. So I love that innovative way of doing that. So we're wrapping up here a little bit. And so we've got our last question. So the last question, we always like to kind of look towards the future. We've kind of, looked at the past and look where we're at today, but how about the future? What does the future hold for psychotherapy and the use of psychotherapy within the role of the PMHNP? Where do you see, you've already kind of mentioned a couple of different things, maybe opportunities, but what does your crystal ball say about the future?
I would say that I would love to see transition to practice year following graduation. Not for everybody if you didn't think you needed it, but I would love to develop this kind of innovative transition to practice where you kind of could do some clinical supervision, you could do some diagnostic reasoning, and you could also blend more psychotherapy in, because I think the first year of practice as a psych MP is a very difficult transition.
Mm-hmm. Yeah, absolutely. That would be amazing. I think we know patients are only getting more complex, especially with the increasing complexities that all of us are dealing with just in our world and day to day. So I would love to see continued expanding in integrated care settings, continued expansion from an educational standpoint with emphasis on medication management, but also the psychotherapy piece for even more programs than we're currently seeing. And I do feel like from what I've seen, we're kind of moving in that direction. But I hope that this can become more standardized and more just like spread out throughout the entire program for students who are getting these degrees, because it's so important to have this information when you're treating patients.
Yeah, that's great. Joy, you made me think, there is such a thing for undergraduate at APNA, right? They have a transition. And I think I've heard that they've had discussions about making that, into a graduate type of thing. Because I don't think you're alone in your thoughts of, having those resources available. And obviously that's one piece that gets asked for me a lot. I hear that frequently from my alumni is, how do I do this? How do I bill for this? How do I document it? But also just how do I incorporate it into my business? And especially when they get pressures to do those kind of, very frequent visits and kind of minimize the use of their selves and, that relational piece that we were talking about earlier too. So this has been great. Thank you so much. I appreciate your time, Joy and Hannah. Thank you so much for being on this podcast episode. I wish you nothing but the best. I hope you listening, and we'll kind of stay tuned. We've got a bunch of more episodes coming forward. We've got guests scheduled all the way through August at this point, so we're really excited to have some more people on. And please send me some requests or some people you think I should be on, but please like, subscribe, and comment, and we'll be back quickly with another episode of Peplows Goes. Take care.
Carrying the torch through the blood and the rain. We are nurses, the world can't forget. We give our all, no regrets. Modern in our ways, but our roots don't decay. Nurses anthem and it's here to stay. We are nurses.
So here's to the hands that heal, the hearts that stay steady, the voices that whisper you're not alone. Because nursing isn't just what we do, it's who we are.